Our next presenter is Dr. Kylea Potvin. Let's see if I can get this. All right. Dr. Potvin is a medical graduate of McMaster University in 2000. She completed her internal medicine at Dal in 2003, and she was the first resident through the medical oncology subspecialty training program at Dal. She's currently an assistant professor at the University of Western Ontario, and she's a consultant medical oncologist at the London Regional Cancer Program, where she treats breast and genitourinary cancers. Dr. Potvin has a strong interest in education, and she's currently the co-chair of the undergraduate oncology education and sits on the postgraduate education committee. Her research interests are in locally advanced breast cancer and, of course, education. And she's also a mom and a classically trained singer. So with that, I welcome Dr. Potvin.
Okay, so I just want to figure out where my arrows are, up and down. Okay, so I really have to get that changed. I haven't changed that biography. It's so out of date, and honestly, it doesn't really matter. Probably the only thing that I want you guys to know is that I'm an avid and passionate tennis player, and there's nothing better to get frustrations out than to run around, sweat, and hit something really, really hard. So the reason I tell you that is because Saturday is one of my big playing days, and my other passion is my family. And I've set aside both my family and my tennis because I welcome any opportunity I get to come and talk to people, because you're why we do what we do, right? That's why Nick is here, Dean is here, I'm here. That's why we have jobs. We're here because we want to help people. And it's not just the people that we see in our clinics every day. It's when we get a chance just to educate people. So if I can say anything today that is helpful, then that's great. I've done my job, and I feel really good about being here. So, so thank you for the opportunity. To the first two speakers, I really enjoyed it. I learned something from both of you. And to Nick, I would say, be thrilled to say that you are not an expert speaker. Because what we know from math, X is an unknown quantity. And what we know about spurt is it's a drip under pressure. So you're not an expert. You're a fantastic speaker. I work with Nick in London, and I have to actually say since he's come, it's truly an honor and a pleasure to work with him in clinic. I wish we worked even more. And he's an incredibly thoughtful, compassionate, and highly, highly skilled surgeon. So I welcome every chance we get to work together. So really enjoyed that. And Dean, I thank you for using simple PowerPoint slides, because that's all I used. Didn't use the fancy Prezi, so I'm very grateful for that as well. So when I was coming to do this talk, I mean, I'm very used to doing talks for medical students and for residents and for other physicians, and we use a lot of terminology, and we kind of know what we want to teach people. But I pulled some of my non-medical friends, and I pulled my husband, he's still a physician, but a very practical thinker, and I just said, look, I'm going to do this talk about chemotherapy and testicular cancer. I think I know what I want to say or should say, but I'd like you to tell me, if you were a guy or a family member of somebody, and you were going to come and hear someone talk about chemotherapy and testicular cancer, what do you want to know? So this is what I was told. These are my objectives. Why do I have to have chemo? How much will it suck when I'm having it? How much will it suck in the future? And how well does it work? So I think if I can cover that for you and any other questions, then we'll be ahead of the game. So the first thing I'm going to talk to you about is why we do chemo in testicular cancer. And some of you already may have experiences here with it. Some may not. Some may be looking at it. So the reality is we use it in very different situations in testes cancer. But as an oncologist, one of the things that I can say as a chemo doctor is really I think this is one of the only cancers that we can say where the chemotherapy is the primary part of actually curing the cancer. Most of the time our chemo is to help along what really the surgeons have done primarily, or sometimes our radiation oncologists do the primary form, and we give a little helping hand chemo. But in testicular cancer, there are situations where what we do is actually the cure for it, and it's really an exciting thing to be a part of where cancers are concerned. So why do we do chemo in testes cancer? Well, let's start with early stage. So stage is just in reference to how far in the body has this cancer spread. And that's important. So when we're talking about early stage, we're really talking about a stage 1, or a cancer where the tumor is still confined to the testicle. There's no sign that it has gone anywhere else. You will see your surgeon, they take the testicle out. And then sometimes you will see someone like me for a consideration of what happens after that. Sometimes we talk, and most often we talk about an active surveillance or a watch and wait approach. But there are pros and cons to that approach. And what we're really worried about with the surveillance and with any cancer is anytime you've had a cancer, there are a lot of things that make cancer a cancer, but what it really is the most important is its ability to spread. So if you have a cancer and it appears to be confined, what we worry about is there may be cancer cells circulating in your body. So that's why we watch men very closely after they've been diagnosed with a testes cancer that looks confined. We want to catch it early if it's going to spread because we can still cure it at that point. Now, those schedules to be watched are pretty rigorous. They have tests, they have blood work, they have clinic visits. And it's really important that guys are going to do it, that they're reliable at doing that. Some guys, if they're honest with us, or if we can identify social risk factors that might suggest they may not be able to adhere to that kind of watchful waiting schedule, we can talk to them at that point. They have no evidence of cancer, but we can talk to them about this concept of adjuvant chemotherapy or preventive chemotherapy. So what that means is you've got a guy, he has no sign of cancer, but we're worried that he is at risk for recurrence because of what we see in the primary tumor. So we can give some chemotherapy at that point, and what it is, it's a mop-up. Chemotherapy, it's treatment, it's systemic. It goes through your whole body. And so the idea is that you can actually kill those cancer cells before you see signs of them growing or spreading somewhere else. So it's really the concept of preventive treatment. So we'll sometimes do that up front. And so that makes those follow-up schedules less rigorous. They have to come less often. We're less likely to have somebody come back to us with a highly advanced tumor. Sometimes we'll actually do it after there has been surgery performed. So there are situations where guys have had their primary testicle removed, and then their scans may show enlarged glands in the belly, as Dr. Power told you earlier. And some men will actually opt to go have those taken out. These are complicated, not easy decisions, but some men will opt to do that. And if there is actual active cancer, they'll come back and see someone like me, and we will do that same kind of adjuvant, preventive, or mop-up chemotherapy at that point. In these situations, we tend to give a little less chemo in terms of the number of courses of treatments, or we call them cycles, in this kind of setting. But really, when you look at early stage, the reason for us doing chemo, why we would do it at this point, it's to try to prevent cancer recurrence in guys where we think that there's a high risk of it. When you get into metastatic disease, so that refers to more advanced disease, stage 2 and 3, where there is evidence that the cancer cells are now spreading to other parts of the body. So lymph nodes, and it'll travel generally, predictably, with most types of testes cancers to lymph nodes in the abdomen, to lymph nodes in the chest. Then you can get spread out into the lungs, then to liver, bone, brain, other organs in later stages. So this is metastatic disease, and this is where we come in with chemotherapy as really the primary form of treatment to cure this kind of cancer. And we can, even in this late stage disease. So we are still talking about curative intent treatment, even in disease that is widely spread. And that's something that's also highly unusual with cancers. The vast majority of cancers, when you have spread to organs outside of where the cancer started, it is very uncommon to actually be able to cure those. We talk about disease control, quality of life, long-term remission, but this is one of the few cancers where we can actually say when it has spread to other places, there's still a very good chance of cure. We start with what we call first-line treatment. So that's the first kind of chemotherapy somebody would get for their disease when there's evidence of spread to other places. There will be a large number of men that are cured with that first-line therapy. Unfortunately, sometimes, we tend to follow guys closely after this, there can be recurrences or cancer coming back. And at that point, then it's second line, or what we refer to as salvage treatment. And we are still able to cure guys even at that point. Sometimes it gets more complicated when we get into those kind of recurrences. And that's where these other things I put on here, stem cell transplant, high-dose chemotherapy, those are very special circumstances that can come into play. But again, the goal, as much as possible, whenever we think we can, the goal is to try to cure people. So these are the main indications. And finally, there are some situations where we end up with guys that we can't cure, that continue to have progressive disease. So we will use chemotherapy in those situations, not to cure the cancer, but really with the goals of maintaining quality of life and extending life for patients as well. Okay, so here's the question. How much does chemotherapy suck when you are going through it? So it sucks, and I will say that wholeheartedly. When we all do our jobs, I think that we can all get into situations where it can become a little bit rote. There are certain things where it's like, okay, I've got to see this patient, discuss this. I think one of the things that I have not lost respect for through the course of practice, I've been practicing for about 8.5 years now, maybe a bit longer, as a consultant. I've not lost the respect and admiration I have for any patient of mine who goes through chemotherapy for any indication, because while people can do really, really well with it, and generally with all the supportive treatments we have, we can get people through really well. But I know that if there's ever a day I have to sit in a chair and have a needle put in my arm to have treatment, I will be absolutely terrified, and I deal with this every day. So I think that we can manage patients through really well, but I do think it sucks. And I'm just being honest. So, what's chemo? I think we all, have the vision in our minds. Some of you have gone through it, so it's more than a vision. You've actually been through it. Some of you may have family members. Some of you may have no experience with it. When it comes to treating young, healthy guys, or mid-aged healthy guys that come to me, one of the first things I do have to explain to them and to the healthy people that come along is, I ask everyone, and I can still tell you that 99% of the time right now, what I get is someone describing for me a dying cancer patient, somebody lying in bed, vomiting, wasting away, no energy, that's what they describe. So the reality is, for most people, for example, people in this room who would go through this or in this age range, that is not the picture of what chemotherapy is like. Chemotherapy is, if we can support it well, most people can function and engage in normal activities. I have some of my testes guys who went through chemotherapy and still wanted to play their hockey and do other things. We had to have some conversations about contact and blood counts and where they are in their cycle. But I do like people to carry on as normally as they possibly can, because the more physical you are throughout, the better you're going to get through, the more normally you're going to feel. But there are things that you have to alter, you have to be careful about. But chemo's poison. There's the kind of chemotherapy we use for this cancer is poison. It's meant to kill cells that are growing quickly, because that's all cancer cells are. They're just cells that have thrown off growth controls, they're growing, they're spreading, they're dividing. So the way chemo works, there are all kinds of different drugs. I put the names of the drugs that are used most commonly in testicular cancer, but they are drugs that attack the cell division process at various points in it. So it's a poison and it's a toxin, and that's the reason we're going to talk about side effects, why people get the side effects they do. It's because while we're killing the cancer cells, we are impacting the other normal functions and organs in your body while we're doing it. So that's why people get the side effects. So it's a poison, it's given with purpose. We give multi-agent chemotherapy, meaning we give several drugs together, and the reason for that is it works better than just giving one alone. Cancer cells, they mutate, they change themselves. They develop mechanisms for resisting sometimes of some kinds of treatment. So when we give more than one together, we can overcome some of that resistance and our cure rates are higher. And there's lots of studies that have been done in testes cancer. We have actually some, for the most part, very clear idea of what kind of chemo we should give, how often, how much. So we give set numbers of cycles. I'm going to address that a little more at the end. Those letters that I put together, BEP, EP, TIP, VIP, GEMOX, these are some of the more common regimens that are used. So if you were ever to be offered chemotherapy for testes cancer, inevitably some of these are what you will see. It's up to the oncologist in the situation to determine what is the best in that given circumstance. But these are really the most common things, all right? They are all intravenous drugs for the most part. There is one drug that can be given intravenously or orally, but for the most part, all of them are given through the vein, and they are given in cycles. So a cycle of chemotherapy refers to the actual number of days of treatment that you're on active treatment plus your recovery days. Most cycles for testes cancer treatments are about 3 weeks, and there are some varying things in there. I'm not going to go into the details of that, but it's just to give you some knowledge of what is chemotherapy, what is a cycle, how do we give it, okay? Stem cell transplant is done as a patient in hospital. Salvage chemotherapy, often because the regimen is given as an inpatient. The more standard regimens, the BEP, the EP, those can be given as an outpatient, so you do not have to be hospitalized for your chemotherapy treatment in some cases. Okay, so it'll suck. So some of the things as far as side effects with chemotherapy, these are the things that they're nonsense and nuisance things, and I don't say that lightly by any stretch, but they are the things that are fixable, manageable, and recoverable for the most part, and for the most part generally won't be life-threatening to you. So there is no question, if I were to cumulatively poison you again and again and again, if you got nothing else, you are going to feel tired. And this is very intensive treatment that we do because it is curative intent treatment. And we do tend to actually push people through a lot of side effects. Unless I have to dose reduce, I do not dose reduce drugs. I try not to have any delays with treatments. So even when people are actually just feeling like utter crap, we will still push you through because the intent is to cure you from your cancer. And we definitely know with cancers that staying on time with treatment and maintaining the maximal doses we can is really important in those cure rates. And this is also very well studied in testis cancers. They've compared different drugs, doses of drugs, trying to increase, decrease, and we've found what works. You will get tired. These are the kind of chemotherapy drugs that lead you to lose your hair, because hair is something that grows. I don't take that lightly either, and I don't take it, most guys are pretty, oh, you know, no big deal, but I don't take it lightly because it's a very visual thing. You know, there are certain chemo drugs that don't make you lose your hair, and people wouldn't even know you're on it, but as soon as you start into these regimens, you do lose your hair, all of a sudden you become more visible, you know. There's a certain look. Guys tend to get a little red in the face, a little puffy, they lose their hair. The redness in the face is because of some of the supportive drugs that we use that cause a bit of flushing. The hair loss is while you're on treatment. Once the chemo is done, given a bit of time, hair comes back, and you can lose hair everywhere. So that may be a good or bad thing, depending on, you know, where you stand. So nausea and vomiting can be a big problem. One of the drugs that we use is a drug called cisplatin. It's a highly important drug in testes cancer, but it is a bad culprit for a lot of things. So this drug, nausea and vomiting, can be a problem. Thankfully, we have a lot of good supportive drugs, but sometimes even with the most maximal therapy, we can still have people have trouble. But there are a lot of things. The vast majority of people were able to keep them feeling just fine. Your taste and smell goes wonky. There's no avoiding it, so that can throw you off your food. Heartburn, again, these are all common things. You can get little canker sores in your mouth. You can get your hands tingling, burning, your feet tingling, burning, ringing in your ears. These are all evidence of fine nerve damage, again, resultant in some of the drugs. This can be reversible in many people, but there is a risk of long-term nerve damage and long-term hearing loss with these drugs. So these are things that you have to be aware of depending on what kind of work you do. There can be an impact with that. You can get real crazy skin changes. So I already told you can get kind of flushed with it. If you have scars, they can become very dark and pigmented. If you cut yourself, it may scar very dark and pigmented. And there's a crazy rash. It has a very fancy name. I've seen a case of it. But it looks literally like someone has taken their nails or a whip and just clawed, you know, on your back. It's a really, really unusual presentation. I have seen one case, and when the guy came, and it was painless, like completely painless, not itchy, and I just told him, hey, look, you look kind of cool on a beach. So it will fade out and go over time, but it can take some time. But you can get a lot of skin changes. You can get a lot of redness and tenderness in the fingertips and the hands. So these are all things that can happen. Sore joints. The bowels go nuts because of the chemo drugs, because of the supportive medication. So your whole system just takes a dump, takes a dive. These medications really do affect everything. Your blood cells, your white infection fighting cells, your platelets, your clotting cells, all of these cells and your hemoglobin, your oxygen carrying cells, they're all going to go like this when you're on treatment. And that's because of the chemotherapy, and we know it. And that's part of the reason why these cycles are 3 weeks apart. What you need to know is you are at risk for life-threatening infections. And these aren't the head colds and the minor coughs that we all suffer through, probably more this year than before, given how long this is going on. But, you know, it's really bugs that reside in our own bodies, on your skin, in your guts, in your mouths. These can get into your bloodstream. Every time you brush your teeth every day, you get bugs in your bloodstream. But your immune system's normal. So when that happens, it'll get rid of them. Your immune system is not normal when you're going through chemotherapy. We can use medications to try to keep your infection-fighting cells, but they are not perfect. So there is a risk, and this is where Dean had said something. I'm going to misquote you, but he said, listen to your bodies and stay in touch with your doctors. This is so important on chemotherapy. You really, really need to pay attention to what you're feeling, because sometimes signs of infection can be really subtle. It can just be, I feel a little weak or more lightheaded, or those can be early signs. You need to watch your temperature, because if you get any hint of infection, these can be life-threatening. You can die from these infections if they're not treated appropriately, so you need to get your blood in for assessment, okay? Okay, I'm not coming to Toronto and not making fun of your hockey team, because they really suck too, sorry. Seriously, I've never seen a team that can implode like this, unreal. Serious snatch defeat from the hands of victory. So you have my pity, I'm really sorry. Okay. Okay, a couple of good things. Like I said, most guys can get through this. I've had some guys actually attempt to work. I don't advise that unless there's no way around it because of the risk of side effects, of infection, of the problems you may have if you get really sick, and just the fatigue. It is really, really hard. If you're going to go through chemotherapy, your focus should just be taking the best care of yourself you can. Your nutrition, your exercise, your rest. That's your focus when you're getting through treatment. So I don't advise working. The scheduling of these treatments can be a bit wonky. Sometimes you might have to be admitted to hospital for 5 days. Sometimes you're coming in for a week straight and then an alternate day other weeks. It makes it very difficult. Like anything, we have a Canadian system that's quote-unquote universal. There are hidden costs that people are not aware of with cancer. And there are people, especially in the young age range, that can slip through the cracks. It's not the chemo drugs. The chemotherapy drugs are covered. It's the supportive medications that go along with it, the anti-nausea pills. We now have the growth factors covered for this, which is good, but at one point, those are thousands of dollars. At one point, those weren't covered. But there are a lot of medications that are not. Some of them are cheap, but there are some of the anti-nausea medications that are highly effective, but $125 every time you go for a cycle of treatment. It's not small dollars. I would tell you that most cancer centers have patient assistance funds that can help. I would encourage you, if there's a social worker or some kind of supportive services at the center you're going to, seek them out because they will have ways of getting you, for example, through home care services or Trillium. There are ways we can get you drug coverage, but it's a process. It can take some time. But there can be out-of-pocket expenses. If you have private health insurance, that's great. Most of them will cover it. But this is something to be aware of, that you may end up having to pay some money. But seek out what supports are there, because there are some that will help. More bad news. Sorry. So I talked to you about things that are things that people experience, but I said they're reversible, they're fixable. There are serious things that can happen, and some of them can be short-term, some of them can be long-term, but these are serious and life-threatening things that we know about when we treat testes cancer with chemo. Blood clots. So that is a blockage in one of your vessels, a vein or an artery. The legs and the lungs. This is recognized with the kind of chemotherapy we use in testes cancer. The risk is higher than the average person, than other cancer types going through chemo. So if you get swelling in your legs or a shortness of breath and a cough, this really needs to be taken seriously. This is curative intent treatment, and this is where patients and doctors and nurses and supporting staff, we really have to work well together. I have had a patient die of a blood clot, and it was just basically, he wasn't aware of that what he was feeling was a blood clot. By the time he went in to the emergency room, he'd hemorrhaged out into his lung, and there was nothing that could be done for him, but he was being treated for cure. And for someone, you know, like all of us in this room, when it's a cure and we lose somebody because of a complication that's treatable and preventable, that is the worst thing to experience. So be aware of your body. If there are symptoms happening that don't make sense to you, please, you are not a bother. You call us, you go into the emerge, but please listen to what's happening to you and seek attention for it. That's really important, okay? There was mention in one of the talks about lung toxicity and a drug called bleomycin. This is really, really important, okay? It's a dose-dependent side effect. Bleomycin is a really important and effective drug in testes cancer. We prefer to use it if we can, but there are situations with patients where we actually will avoid using it. If people have underlying serious lung disease, for example, we have a patient with cystic fibrosis right now undergoing treatment. He is obviously not going to receive a bleomycin-based regimen. So there are alternatives that will work. Certain people have habits or things that they do, people that like to deep sea dive, people that are heavy athletes, where we may impact their lung function. We will think twice about using this drug. So it's actually really important when you see your doctor that it's not just your medical history. If there are things really important to you, you should let us know in terms of your hobbies and other things that you do, because that will come into play with this decision. We do test your lung function at the start of chemotherapy, and we test it again partway through, because sometimes we have to give a certain number of doses of it, and we need to know we're safe to do it, okay? This is important because it's not just a short-term risk, it's a long-term risk. This drug can actually cause, it's free radical damage, there are things that can happen in the lungs, and it can be a problem in the long term as well. So, you know, it's important if you have surgeries down the road that the anesthesiologists and surgeons are aware that you have had bleomycin as a drug, because it's going to affect how much oxygen they give you and how they manage things. That's really, really important. Even 10 or 15 years down the road, please mention it. If you look at the literature, the rate of fatal death from this is about 4 to 5%, which is not insignificant with cumulative doses of it. And if you treat long enough, you will have a death from this, and I have had a death from this. And when you look back at things, it's very hard to pick out when it started, but when this inflammation happens, it changes very, very quickly, and it's very hard to get on top of when it does. So from your point of view, if you start getting a cough, bring it to attention, because that would need immediate assessment for this, okay? So this is in the short term, it can happen in the long term as well. Infertility has been mentioned. That is very important, and we have a process in London that we use for sperm banking. So keep this in mind. Even for someone who's in their teens, they're not thinking about kids, you know, but it is something that has meaning down the road. So it is really important to actually be aware of that. And most, essentially, oncologists that are going to treat you for this are going to discuss this with you. And it's not just chemotherapy. Your radiation oncologists will as well if you're needing that kind of treatment. And the costs, again, are not insubstantial with this. Okay, how much will it suck in the future? I couldn't think of a better poster child for cardiovascular disease and a heart attack than this guy, who you also really know well. So I'm in Toronto, I have to make fun, I'm sorry. Anyway, okay, so that's sort of immediate with chemotherapy. And the one thing that I will mention to you is, with chemotherapy, when you finish your last cycle, 2 or 3 weeks later, you're not just going to bounce back and feel normal. You take the time that you're on chemotherapy and at a minimum double that time. It takes a while, and then bring in the hypogonadism, the low testosterone and things that can come into that, because chemo can do that too, right? You take all that into account, it's going to take you a while to bounce back. So don't expect when your treatment's over that everything's going to be hunky-dory. Just, you know, work with your body, all right? Okay, so future things to consider, long-term risks. So cardiovascular, there is data out there about long-term survivors of testicular cancer, and particularly those who do go through treatments. With chemotherapy, there are some specific things that we know about. Some of them we really can't do anything about. There are some things that you as a person should take responsibility for, okay? Cardiovascular disease, we know that there's a higher incidence of it in men who've gone through chemotherapy, and that the onset of it can be earlier than the average man in the population. The metabolic syndrome is just basically the picture I showed you. Big fat guy, high cholesterol, high blood pressure, diabetes. Okay, that's a setup for a stroke and a heart attack. High blood pressure, these other things, your weight, physical exercise, your job, you know, are the job for all of us, but even more so if you've gone through chemotherapy, is to maintain the best health you can, particularly from a cardiovascular standpoint. So do the things that keep your cholesterol down and your weight down, and you know, your physical activity, all those things we know about. Reasonably healthy diet. I say reasonably because nobody's perfect, right? But do the best to maintain the best cardiovascular health and fitness that you can. That's the one preventive thing that we can do. There is a risk of second cancers with chemotherapy, and the second cancer that we are most culprits for are actually leukemias related to some of the drugs that we use. The risk is low. It is dependent on doses of certain drugs. So men who have to go through salvage therapy, meaning more than one kind of chemotherapy, their risk is going to be higher than someone who just receives one course, one line of chemotherapy treatment. It's not a high risk, but it's there. It's about 0.5% to 5% depending on the cumulative dose. So that translates to about 16 cases for every 10,000 men in some of the literature that's published on this. It can happen anywhere from 3 years after to 7, sometimes later. The issue around fertility, low testosterone, that's been really well discussed for you. And that, again, as was mentioned by Dr. Ward as well, this is a long-term risk. This isn't something that just goes away immediately. This is something that can present itself years later. So in answer to some of the questions that were there it's now, you know, if you are aware of this, this should be discussed. Yes, you should monitor your testosterone, and you should just monitor how you're feeling, because if you're having those symptoms, you know, we do query these symptoms in our surveillance clinics as well. That's a trigger for testing, because again, it's something fixable that has a major quality of life impact for you. And then the long-term issue I mentioned already with the nerves, the hearing, and this issue around the lungs. Okay, so how well does this work? So we all know who this is. It turns out, unfortunately, he's a bit of a jerk, and I wish he was a better ambassador. But the other thing that's really interesting is that there's concern that erythropoietin is actually and supplement with it could be a cancer growth stimulator. So I don't know what to say about him. But it works well. He had widely metastatic disease when he was diagnosed, and he was treated for this. He lives on. You can take away the trophies, but he did accomplish, obviously, phenomenal feats. We can debate the whole, should athletes dope or not. I'm happy to engage in that discussion offline. But how well does this work? It works great. When you look at testes cancer, The overall survival rate for all comers is 95% or higher. When you break it down, I'm so sorry that this table is not clear. What this table is, it's a risk stratification system. So if someone comes to us with cancer that has spread and we have to give them chemotherapy, we look at a few things. We look at the kind of testicular cancer you have, so seminoma versus non-seminoma. We look at how high the proteins are in your blood. So the proteins some of these tumors secrete, we look at that, and we look at where it has spread to, and we plug this into a system, and this is based on data and outcomes from patients treated for metastatic cancer. And what we know is if you fall into certain categories, a good risk category with chemotherapy with spread disease, your 5-year survival is 90% or better. If you're in the middle category or this intermediate risk, your survival is 80% or even higher. When you get into the poor risk category, your survival is about 50%, and that number we tend to nudge up when we start bringing in high-dose therapy and transplants if they're at salvage and things. But in essence, to show you, these are 5-year cancer-free survival rates in patients, which is incredible because this is metastatic disease. I can't show you another solid type of cancer with widely metastatic disease that has this kind of survival with it at these time points. So chemotherapy is not a fun experience, but it works. So is it worth it? It's worth it. You have a high cure rate. It is really tough to go through it. There are a lot of things, as I've gone through with you. Most of the side effects are highly manageable. I said don't be a tough guy, because there are a lot of people that tend to try to be stoic and they're going to tough it out. This is the one time as a guy where you can lie on the couch and whine and say it's horrible, and we should listen to you, okay? So this is the time to have people take care of you. But I think the bigger thing, I'm joking a bit, the bigger thing is pay attention to your body and what you're feeling. And if something doesn't make sense, ask for help, because with chemotherapy, waiting it out to see how things go, taking a Tylenol or whatever, that is not a smart thing to do, because that can lead to very serious potential side effects. All right? Long-term issues are there. You need to be proactive about your health. You've been proactive enough, obviously, to seek diagnosis and treatment, but after the treatment's over, it does not end there. So I've tried to let you know about the risks of heart disease and other problems. Be as proactive as you can. All right? So sometimes it's worth taking drugs. That's all I can say. That's it. Questions?
We have a few questions.
Sure.
I think we'll go to the questions in the room.
Sure.
So I have a question. So if you're on chemotherapy and you were having intercourse, and say the woman's on some form of birth control, should he be wearing a condom? Because can the chemotherapy make someone like myself sick if it gets into my system?
I think it's a great question. I mean, we advise all guys to be using a condom during. I mean, chemo can excrete out of, any of your secretions that come out. I think the risk of like a serious dose to you or to another partner with that degree, pretty unlikely, but it's just a common sense, safety that yes, that should be. But no, I don't think you're going to get a substantial or significant dose of treatment that would affect you because of that. But still, the precautions are there because there can be some exposure.
With the bleomycin, is it likely to compromise your lung function or guaranteed to compromise your lung function?
So the interesting thing is, if we were to do scans on like CT, high-resolution CT scans on every guy getting bleomycin through their treatment, we probably would identify changes in, like some kind of lung changes in all of them. Now that's on a very high-resolution scan. A plain X-ray won't show you anything. I do listen to, like all my patients that are on chemo come in, I listen to their lungs, because sometimes before anyone's even having symptoms, you can hear the little Rice Krispie sounds in there when they're not having symptoms. So the chances are there probably is some degree of impact on the lung in every guy who gets bleo, but the actual risk of clinical manifestation of it's incredibly low. And as long as you're aware in terms of the long term, the long-term risk is relatively low. But yeah, there probably is some effect in everyone who gets it. I don't know what to tell you. I don't think anyone has a really good answer about, truly what are risk factors, why some guys get it or don't, except the dose dependence. So, that's where I didn't get into numbers of cycles and that kind of stuff, because that's, beyond time and really not as relevant. But it is important for us. That's why we do those lung function tests to see. There's a measure we call it's a corrected diffusion capacity, amongst other things that we follow to see if we can continue to give it. If it drops by a certain amount, then we'll bail out and we'll switch to a different regimen for that.
Question from someone joining us over the internet about the connection between bleomycin and recreational oxygen scuba diving. So he said he read you cannot do that during the chemo cycle. Does that continue after the chemo cycle as well?
It's, you know, I don't know what to tell you exactly about the time frame. Is this something that you have to give up for your entire life? No. But I do think, and this is where, again, I'm not a scuba diver, an expert in terms of mixes of oxygen and stuff. This, I would actually, for someone who is engaged in that as a heavy recreational activity, I would actually get a consultation with a respirologist and talk to them about that, because I don't have the expertise. I just know that there is a, you know, to say specific time frames, but there can be a long-term risk in the future. So no, you don't absolutely have to stop it, but I think that you'd have to be as informed as possible by a lung specialist, and then to people obviously that are very skilled and experienced with scuba as well. I would be very, very careful with it. So yeah, I would, like I said, ask the expert on that. I am not the expert, but I would send people to who is.
A couple other questions online. You may have touched on some of this, so
That's
don't really need to repeat yourself necessarily, but cisplatin, what are the long-term effects?
So the nerve damage is one that can be clinically apparent to people. So the feeling for people, numbness and tingling in your hands and your feet, loss of sensation. Depending on how much of the cisplatin you get, because again, it is used quite heavily if people have relapses. We don't stop using it because it's so active. So, I mean, if you go to some places like Indiana, where they do a lot of research and there's a lot of heavy treatment, I mean, there are probably people there that, I know one of the oncologists I worked with who did some training, you know, they had actual people that were muscular cripples at some point. So on average, that is not going to happen. What you may be limited to is a bit of pins and needles feeling in your hands and feet and loss of sensation. That's a long-term risk. Hearing loss is a long-term risk. We actually do audiologic assessments in our patients. It doesn't mean I won't give the chemotherapy, but it is something to be aware of over time, because it is that high-pitched conversational hearing loss. So it's something that, you know, you should have monitored during treatment and probably have followed after with the audiologists to make sure. There can be impact on the kidneys as well. The most common thing that we see is not something that patients feel. What we'll see is wasting of some of the salts in your body, your potassium, your magnesium. These are things that we often end up replacing, so you'll end up on supplements while you're going through treatment. There can sometimes be some long-term wasting syndromes with that. I've seen most of my guys recover from that, but there can certainly be impact on the kidneys with it. So, and again, it's not the most common culprit for long-term leukemia, as the other drugs we use are, but those would be the big things: the nerve damage, kidney issues, and the hearing issues in the long term.
And one other one about bleomycin, should you wear a medical bracelet when you're on it to contraindicate oxygen during emergency?
That's a really good idea. I honestly must admit I haven't advised my patients to wear medical bracelets. To be totally honest, I do talk to every single one of my patients and their family members about this, and that you need to make, you know, future surgeons aware and stuff. But in the event of an emergency where you don't have somebody there, that could be an issue. And it is a serious enough one, particularly through the acute phase of treatment and, you know, for a year or two afterwards in that highest risk period. Yeah.